Disease can be understood as a disturbance of harmony, a disruption of the body's normal balance. When disease occurs, the ordinary functions of life, metabolism, growth, reproduction, responsiveness, and movement, are altered. The causes of disease are many. Risk factors lie all around us in food, air, and environment. Harmful stimuli, often described as stressors, threaten the body's integrity and endanger health and survival. The internal environment, the interstitial and extracellular fluids that bathe every cell, must be kept in balance for cells to live and function. Homeostasis is the system by which the body maintains this steady internal environment despite changing conditions outside. Through constant adjustments, the body responds to everyday challenges so that temporary or local changes are soon corrected. But if homeostasis fails, normal function cannot continue, symptoms appear, and disease develops. The causes of disease are collectively called etiologies. Some changes are specific to a given cause, while many nonspecific changes appear across different diseases. For example, kidney filtration of plasma, regulation of fluid and osmotic balance, buffering of blood pH, and pulmonary gas exchange are all vital to maintaining equilibrium. When these fail, disease is inevitable. Among the most important modern concerns are lifestyle-related diseases. Before 1996, these were called adult diseases, but the concept was redefined. Today, lifestyle diseases are understood as conditions whose onset and course are influenced by three categories of factors: genetic predisposition, external factors such as pathogens or toxic substances, and lifestyle habits such as diet, exercise, smoking, and drinking. Because lifestyle can be modified, many of these diseases can be prevented or slowed by behavioral change. Yet, genetics often plays a role as well. In truth, lifestyle diseases are multifactorial, arising from a complex interplay between inherited traits and environmental exposures. Pathology is the field that studies these processes, seeking to understand disease at the level of tissues and organs. One major branch is autopsy pathology. Here, examination of the body after death, particularly in patients who receive treatment and nursing care, reveals how disease progressed, providing lessons for medicine. Another branch is diagnostic pathology, also called surgical pathology. In this domain, samples of diseased tissue are obtained by biopsy or surgical excision for microscopic examination. Biopsies may come from the stomach, intestine, lung, kidney, liver, prostate, breast, or bladder. With the advent of fine needle biopsy, tissue can now be obtained from deep organs through the skin, expanding the role of pathology in clinical medicine. During surgery, frozen section analysis can be performed. A small portion of tissue is rapidly frozen, cut, stained, and examined within 10 to 20 minutes, allowing the surgeon to confirm a diagnosis and decide on the next steps in real time. A further branch is cytology. This involves collecting individual cells shed from the surfaces of hollow organs or body cavities, smearing them on slides, and examining them under the microscope. Cytology is particularly valuable for detecting malignant or cancerous cells. Because it is minimally invasive and suitable for large-scale screening, cytology plays a key role in the early detection of cancer in populations at risk. In this way, disease is seen not simply as disorder, but as a subject for systematic study, from the causes that disturb homeostasis, through the clinical conditions that result, to the microscopic analysis of tissues and cells that reveals their secrets. Pathology is the lens through which medicine interprets these changes, guiding diagnosis, treatment, and prevention. All life in the body begins with the cell. Cells are the fundamental units of structure and function, the smallest living building blocks of the body. Some organisms consist of only a single independent cell, observable only under a microscope. The human body, however, is composed of countless millions of cells, each highly specialized, yet working together as one community throughout the span of life. Within each cell lie organelles, the miniature organs that carry out essential tasks. Suspended in the cytoplasm and enclosed by the cell membrane, these structures allow the cell to survive, grow, and reproduce. The nucleus, the largest organelle, stores DNA, deoxyribonucleic acid, the genetic material that directs inheritance, regulates regeneration, and controls cell division. Animal cells contain several other important components. ATP, or adenosine triphosphate, the energy currency of life, is produced in the mitochondria. Ribosomes, together with the endoplasmic reticulum, synthesize proteins and help in the processing of fats. The Golgi apparatus modifies and distributes molecules, functioning as a packaging and enzyme system. Lysosomes contain digestive enzymes that complete the breakdown of materials inside the cell. Beyond the level of individual cells lies a wider principle: homeostasis. This is the body's continuous effort to maintain a steady, dynamic balance, a state in which conditions remain within limits compatible with life. Every cell contributes to this balance, and organs do so as well. But when external stressors disturb it, whether injury, malnutrition, parasites, or invading microorganisms, disease can result. A small disturbance at the cellular level can ripple outward to affect the whole body. Over a lifetime, human beings face many such stressors, each of which challenges the body's inner equilibrium. The brain helps preserve homeostasis through three key structures. The medulla oblongata, part of the brainstem, regulates vital activities such as breathing and circulation. The pituitary gland governs other endocrine glands and plays major roles in growth, maturation, and reproduction. The reticular formation, a widespread network of interconnected neurons, integrates responses essential to survival, influencing cardiovascular and respiratory activity. Homeostasis is maintained by feedback mechanisms. These self-regulating loops have three elements: sensors that detect a change, control centers that interpret the information, and effectors that carry out corrective action. Endocrine glands, through hormone secretion, often serve as part of the sensing and responding machinery. For example, when blood glucose rises, sensors detect the change and send signals to control centers in the brain. The pancreas is then stimulated to release insulin, lowering blood sugar back toward normal. Cells can be injured in many ways. Toxic injury may be intrinsic, such as from metabolic defects, congenital malformations, or hypersensitivity, or extrinsic, caused by alcohol, lead, carbon monoxide, or drugs. Infectious injury arises from viruses, protozoa, or bacteria. Physical injury may come from heat, electricity, radiation, trauma, or surgery. Deficiency injury occurs when essential nutrients or substrates are lacking. Each type of injury, whether minor or severe, threatens cellular balance and thus the health of the body as a whole. When cells and the materials between them combine, they form tissues. A tissue is a structural unit in which living cells are supported by intercellular substance. Only the cells themselves are alive, but the surrounding material provides the environment that allows them to function. Bathing these elements is tissue fluid, the liquid that moves between blood and cells, transporting nutrients, oxygen, and wastes. There are four primary types of tissue. The first is epithelial tissue, which covers the body's surfaces inside and out. Functionally, epithelium can be protective, shielding external surfaces and the linings of organs. Absorptive, as in the digestive tract. Sensory, containing cells that detect stimuli. Germinal, giving rise to reproductive cells. Glandular, secreting substances through exocrine or endocrine activity. Or specialized in forms such as keratinized epithelium in the skin, calcified epithelium, mucus-secreting respiratory or gastrointestinal linings, lipid-laden tissue, and pigmented layers in hair and skin. The second is connective tissue, which provides support. Unlike epithelium, connective tissue does not cover exposed surfaces, but instead fills spaces, connects structures, and protects organs. It lies under the skin, beneath mucous membranes, between lobes of organs, and around muscles and tendons. Types include areolar connective tissue, dense fibrous tissue, reticular tissue, and the cells of the reticuloendothelial system. The third is muscular tissue, the engine of movement. Composed of long, narrow muscle fibers, it is excitable, contractile, extensible, and elastic. Muscle fibers contract in response to stimulation, then relax and return to their original state. According to structure and function, muscle tissue is divided into three kinds: skeletal muscle, cardiac muscle, and smooth muscle. The fourth is nervous tissue, which provides control. It consists of neurons and supporting neuroglia. A neuron has a cell body with dendrites and an axon, transmitting impulses to other cells. In the central nervous system, the brain and spinal cord, the glial cells form the supporting framework, supplying nutrients, engulfing foreign matter, and maintaining homeostasis. Peripheral nerves are bundles of countless axons running together, carrying signals rapidly across the body. When different tissues combine for a specific purpose, they form an organ. The tongue, the eye, the kidney, the bladder, the pituitary gland, and the lymph node are all organs, visible, structured units where tissues cooperate to perform specialized work. When organs link together in sequence to carry out a broad function, they form a system. The skeletal system provides the body's framework and gives muscles levers for movement. The muscular system attaches to it and moves joints by contraction. The nervous system acts as the communication grid, central and peripheral, transmitting and processing signals. The circulatory system carries absorbed substances everywhere through heart and vessels, and often includes the lymphatic system. The respiratory system brings oxygen in and drives carbon dioxide out through the nasal passages, larynx, trachea, bronchi, and lungs. The digestive system receives food, breaks it down, absorbs nutrients, and eliminates wastes, including organs such as the mouth, esophagus, stomach, intestines, liver, gallbladder, and pancreas. The urinary system filters the blood, excreting wastes in urine through the kidneys and bladder. The reproductive system produces gametes and enables the continuation of life through sexual union. The lymphatic system defends the body, capturing and neutralizing microbes and foreign substances. The endocrine system regulates metabolism, growth, reproduction, and coordination among organs through hormones secreted by glands such as the pituitary, pineal, thyroid, parathyroids, adrenals, pancreas, testes, and ovaries. The sensory organs, the eyes, ears, taste buds, olfactory system, and skin, form the interface with the external world. The skin itself is sometimes grouped as the integumentary system. In this layered architecture of life, cells become tissues, tissues assemble into organs, and organs unite into systems. Each level contributes to the whole, and together they make possible the vast range of human functions: protection, movement, sensation, metabolism, defense, and reproduction. Blood vessels are the body's pipelines, carrying blood in a continuous circuit throughout the entire system. They are broadly divided into three types: arteries, capillaries, and veins. Arteries carry blood away from the heart toward every organ and tissue. As they branch and become smaller, they form arterioles, the finest arteries. These arterioles are critical regulators, able to constrict or dilate, thereby controlling how much blood reaches a tissue and directly influencing blood pressure. Capillaries are the thinnest vessels of all. Their walls are only a single layer of cells, allowing plasma to seep outward and deliver oxygen and nutrients to tissues, while at the same time collecting carbon dioxide and wastes. From the capillaries, blood begins its return journey through venules and then into veins, completing the circuit back to the heart. The walls of arteries and veins share a common design of three layers. The innermost tunica intima is lined by endothelium. The middle tunica media consists of smooth muscle and connective tissue, allowing for contraction and regulation of vessel diameter. And the outer tunica adventitia is a layer of connective tissue that anchors the vessel to its surroundings. Between arterioles and venules lie tiny channels called metarterioles, which bridge the two systems. At the entry points of capillaries, precapillary sphincters act like tiny valves, opening or closing to regulate blood flow into each capillary bed. In certain organs, the liver, spleen, and bone marrow, the vessels are especially permeable, forming sinusoids that allow free exchange of large molecules and cells. Circulation itself is organized into two great circuits, the pulmonary and the systemic. In the pulmonary circulation, deoxygenated blood is pumped out of the right ventricle into the pulmonary arteries and carried to the lungs. Within the pulmonary capillaries, carbon dioxide diffuses out of the blood into the alveoli, while oxygen diffuses into the bloodstream. Oxygen-rich blood then returns via the pulmonary veins to the left atrium. From there, the left ventricle propels it into the systemic circulation, sending oxygen and nutrients throughout the entire body. The systemic arteries begin with the aorta, the largest artery of the body, which emerges from the left ventricle. The aorta distributes blood through its ascending segment, the arch, the thoracic aorta, and the abdominal aorta. The thoracic and abdominal portions together are called the descending aorta. Its countless branches supply every organ and tissue. Venous return flows through the superior and inferior venae cavae. The superior vena cava drains blood from the upper half of the body and delivers it into the right atrium. The inferior vena cava collects blood from all regions below the diaphragm and also empties into the right atrium. The brain receives its blood supply from two paired systems. The internal carotid arteries ascend into the skull, while the vertebral arteries travel upward along the spine. The left and right vertebral arteries unite to form the basilar artery. Branches of the internal carotids and the basilar artery interconnect in a ring at the base of the brain, called the circle of Willis, ensuring a stable blood supply. After passing through the brain's capillaries, venous blood drains into the dural venous sinuses, and then into the internal jugular veins, completing the cycle of cerebral circulation. Thus, the vessels of the body form a perfectly orchestrated system. Arteries pushing blood outward, capillaries serving as exchange points, veins carrying blood home. Within these networks, the lungs oxygenate, the heart drives, the tissues receive, and the brain remains nourished and alert, sustained by the continuous river of life flowing through its channels. Cells have limits to how much stress or demand they can endure. When those limits are exceeded, injury occurs. Injured cells often show changes known collectively as degeneration. Causes of cellular injury are many, The most common is ischemia, or oxygen deprivation, when an artery narrows or is blocked by atherosclerosis or by a blood clot. The blood supply to tissues is cut off, leading to hypoxia. Another cause is chemical injury. Toxic substances may enter the body, damaging cells, and, in severe cases, causing cell death or even the death of the whole organism. Often, specific chemicals target specific cell types, for example, antibiotics or disinfectants, damaging kidney tubules, or the herbicide paraquat injuring the lungs and kidneys. Industrial pollutants, automobile exhaust, and food additives may cause both acute and chronic poisoning and even carry carcinogenic risk. Infectious microorganisms, viruses, bacteria, and protozoa also cause injury. Radiation, whether from medical use or environmental exposure, can damage cellular DNA and proteins. Even therapeutic drugs can sometimes act as poisons when misused. Such conditions are called iatrogenic diseases. When cells are injured but not fatally, they often show degenerative changes. These are usually seen in the cytoplasm rather than the nucleus, and are common in metabolically active organs such as the liver, heart, and kidneys. They include swelling of the cell, called hydropic or vacuolar degeneration, where water accumulates in the cytoplasm because oxygen deficiency halts ATP production, impairing membrane pumps. Another form is fatty change or fatty infiltration, in which abnormal lipid vacuoles accumulate in the cytoplasm of non-adipose cells, most often in liver cells, as a result of alcohol toxicity. Cells and tissues may also undergo atrophy, a reduction in size. Atrophy may be physiologic, as when the thymus shrinks after childhood, the uterus and ovaries regress after menopause, or organs like the brain and kidneys become smaller with aging. It may also be pathological. Disuse atrophy occurs when an organ or tissue is not used for a prolonged time, while pressure atrophy arises when persistent pressure compresses tissue, as in hydronephrosis caused by urinary obstruction, or in bedsores caused by pressure on the skin. Closely related is hypoplasia, when an organ is underdeveloped from the beginning. Other cellular changes include autophagocytosis, in which a cell digests part of itself, pigmentary changes from abnormal deposits of pigments, calcification, where calcium salts accumulate in tissues, hyaline infiltration, dysplasia, in which chronic irritation alters cell structure, and hyperplasia, in which cells multiply excessively. When injury is severe and irreversible, cells and tissues die, a process called necrosis. In necrosis, the nucleus shrinks, fragments, and disappears. Lysosomal enzymes are released, digesting cellular contents in a process called autolysis. Different forms of necrosis are recognized. Coagulative necrosis, the most common, is characterized by protein denaturation and water loss, as in myocardial infarction. Liquefactive necrosis is typical in the brain, where tissue softens and liquefies, producing cerebral infarction or encephalomalacia. Caseous necrosis, seen in tuberculosis and syphilis, combines features of both and produces a yellow, cheese-like appearance. Gangrene refers to necrosis complicated by bacterial infection, producing tissue destruction, foul odor, and sometimes gas formation. Mummification is a form of dry gangrene in which water evaporates and tissue dries and shrinks, as in the tips of fingers or toes. Alongside necrosis, there is another form of cell death, apoptosis. Unlike necrosis, which is passive and destructive, apoptosis is an active, programmed process. It is encoded within the cell's own genes, a built-in self-destruction mechanism often called cellular suicide. Apoptosis eliminates cells that are no longer needed, shaping tissues during development and preserving homeostasis in adulthood. In apoptosis, changes are subtle. Organelles remain relatively intact, but the nucleus condenses, chromatin aggregates at the nuclear membrane, and the cell shrinks into small bodies to be removed without inflammation. In summary, cells under stress may adapt or degenerate, but when the damage is too great, they proceed to necrosis or apoptosis. Necrosis destroys tissue with inflammation, while apoptosis quietly removes cells in a controlled, genetically guided manner. Both processes are essential to understanding how health is maintained and how disease develops. When tissues are injured, the body often attempts to restore them to their original state. This process is called regeneration. In certain tissues, regeneration is a natural, ongoing phenomenon, such as in the skin, hair, nails, the uterine lining, and the blood cells, where old structures are constantly replaced by new ones. This is called physiologic or complete regeneration. But in many pathologic conditions, regeneration is incomplete, producing imperfect substitutes for the original tissue. The more highly specialized a tissue is, the weaker its ability to regenerate. Some tissues, such as the lens of the eye, neurons of the central nervous system, and cardiac muscle, cannot regenerate at all. Others, such as glandular epithelium, skeletal muscle, and smooth muscle, regenerate poorly. Still others, like connective tissue, neuroglial cells, peripheral nerves, blood, epidermis, and mucous membranes, regenerate vigorously. Differentiation, the process by which cells acquire specialized structure and function, is central to regeneration. But sometimes cells adapt not by regenerating, but by transforming into another type. This phenomenon is called metaplasia. For example, the columnar epithelium lining the bronchi may change into stratified squamous epithelium in response to chronic irritation from smoking. In chronic gastritis, the gastric mucosa may change into intestinal-type epithelium. Such adaptations help tissues survive, but often come at the cost of normal function. When trauma creates a defect in tissue, the process of wound healing begins. Healing relies on two major components: inflammation and tissue proliferation. A hallmark of the healing process is the growth of granulation tissue, a red, soft, fragile tissue that arises from the wound surface. In the early phase, platelets stimulate the production of type 3 collagen, which is later replaced by type 1 collagen, forming dense, strong fibers. Over time, the fibroblasts diminish, and granulation tissue is replaced by bundles of collagen, leaving behind a scar. Healing proceeds through 3 overlapping stages. First is the exudative phase, when inflammatory cells, especially white blood cells, infiltrate the wound, clot, and necrotic tissue. Second is the proliferative phase, when granulation tissue forms and fills the wound gap. Third is the scar maturation phase, in which the tissue contracts and strengthens. If the wound edges are close together, as in a surgical incision, healing occurs by primary union, leaving little scarring. If the wound is gaping, as in crushing injuries, abundant granulation tissue is required, and the scar is larger. This is secondary union. Healing can be delayed by many factors: advanced age, malnutrition, infection, mechanical instability, corticosteroid therapy, large hematomas, or repeated trauma to the site. The body also has ways of dealing with foreign bodies, substances that do not belong in the tissue, whether they come from outside or from within the body. Granulation tissue often forms around foreign material, attempting to absorb and eventually replace it in a process called organization. Macrophages engulf such material, attempting to digest it with enzymes. When macrophages cluster around an indigestible foreign body, surrounded by proliferating fibroblasts. The structure that forms is called a foreign body granuloma. Beyond healing, cells and tissues may respond to demands in other ways. One is hypertrophy, in which cells increase in size. Another is hyperplasia, in which the number of cells increases while their size remains unchanged. Hypertrophy may be physiologic, as when a weightlifter's muscles grow in response to training, or work-induced, as when the heart muscle thickens in response to high blood pressure. Compensatory hypertrophy can be seen in paired organs. If one kidney is lost, the other enlarges to take over its function. Pseudohypertrophy, or false hypertrophy, occurs when atrophied muscle fibers are replaced by fat, making the organ look enlarged even though its function is impaired, as in certain forms of muscular dystrophy. Thus, the story of tissue response is one of resilience, adaptation, and compromise. Cells may regenerate, transform, proliferate, or enlarge. Wounds may heal with delicate granulation tissue or thick fibrous scars, and the body may surround and isolate foreign intruders. These processes illustrate the constant dialogue between injury and repair that sustains the living body. Circulatory disorders occur when the normal flow of blood through the heart, lungs, and systemic vessels is interrupted. After traveling through the body, venous blood returns to the right atrium, passes into the right ventricle, and flows through the pulmonary artery to the lungs. In the lungs, gas exchange takes place. The blood becomes oxygenated, returns to the left atrium via the pulmonary veins, and is then pumped out from the left ventricle to the entire body. Blood from the digestive tract passes through the portal vein, circulates through the liver, and then merges into the inferior vena cava. At the microscopic level, circulation involves the exchange of substances at the cellular level. This microcirculation takes place through arterioles, capillaries, venules, and lymphatic vessels. One type of disorder is hyperemia, in which arterioles dilate and blood volume increases in the small arteries and capillaries. This usually results from increased function, such as in active muscles, or from emotional factors like excitement or embarrassment that cause flushing. It is temporary and not generally considered pathological. By contrast, congestion occurs when venous return is blocked, leading to stagnant blood in veins and capillaries. Local congestion may result from venous thrombosis, tumors, or hernias compressing veins. Generalized congestion occurs in congestive heart failure, especially when the right ventricle fails to pump efficiently, causing blood to back up in organs such as the liver, spleen, and kidneys. This can produce ascites and edema. Pulmonary congestion is seen in left ventricular failure, such as after myocardial infarction or valvular disease, where blood stagnates in the pulmonary vessels. Collateral circulation refers to alternative pathways for blood when the original vessel is severely narrowed or blocked. Arteries have fewer collateral branches, while veins have more. Some vital organs, like the brain, heart, spleen, and kidneys, have little to no collateral supply, which makes blockages especially dangerous. In portal hypertension, caused by cirrhosis, blood is unable to flow smoothly through the liver, raising portal venous pressure. As a result, blood is diverted through collateral routes, leading to esophageal varices, hemorrhoids, and the appearance of caput medusae, dilated veins radiating from the umbilicus. Rupture of an esophageal varix often leads to massive bleeding and can be fatal. Hemorrhage means the escape of whole blood from the cardiovascular system. It may be caused by rupture of a vessel or heart wall, or by leakage through weakened capillary walls during inflammation or congestion. Hemorrhage can be arterial, venous, or capillary, internal or external, and may present in different forms, such as petechiae, purpura, or hematoma. Clinical signs vary with the site, hemoptysis from the lungs, hematemesis from the stomach, melena in stools, or hematuria in urine. The consequences of hemorrhage depend on the amount and speed of blood loss. Rapid, massive bleeding may lead to shock and death. Chronic small losses may cause anemia. Intracranial bleeding can increase pressure and damage the brain, while pericardial bleeding can compress the heart and lead to cardiac tamponade. Certain conditions predispose individuals to bleeding, called hemorrhagic diathesis. These include coagulation disorders such as hemophilia, due to factor VIII or IX deficiency, usually in males. Platelet disorders such as thrombocytopenia, seen in leukemia or autoimmune destruction, and vascular wall weakness, for example in scurvy from vitamin C deficiency. First, the vessel wall contracts, which helps slow down the blood flow. At the same time, platelets rush to the site of injury. They stick to the exposed collagen and to each other, creating a temporary platelet plug. This first step is called primary hemostasis, but this platelet plug is fragile. If nothing else happened, it would easily be washed away by the moving blood. So the body activates the coagulation system. Through a chain of reactions, thrombin is formed, and fibrinogen is turned into fibrin. The fibrin strands weave through the platelet plug, making it strong and stable. Within just a few minutes, usually 5 to 10, bleeding is controlled. There are two main ways the clotting process is triggered. One is the extrinsic pathway. This happens when blood comes into contact with tissue factor, a protein outside the vessel wall, such as in an injury. The other is the intrinsic pathway, which occurs when blood contacts abnormal surfaces inside a vessel or even the wall of a test tube in the lab. Both pathways eventually meet and lead to the same final result, the formation of fibrin and a solid clot. When clots form inside blood vessels, we call this thrombosis. A thrombus is a solid mass of blood that forms within the heart or vessels. Three things contribute to its formation. The first is injury to the inner lining of the vessel. The second is abnormal blood flow, either stasis, slowing, or turbulence. The third is changes in the blood itself, such as being more concentrated or having overactive clotting factors. Arterial thrombi are made mainly of platelets and fibrin, so they appear whitish. They are often called white thrombi. Venous thrombi, on the other hand, form in areas of slow blood flow, like the legs or pelvis. They are rich in red blood cells as well as fibrin, and therefore appear red. These are often called red thrombi. Sometimes clots have mixed areas of white and red because of disturbed blood flow. What happens when a thrombus grows? If it blocks the blood vessel completely, the tissue supplied by that vessel can die from lack of oxygen. This is called infarction. In veins, clots can cause congestion and swelling. Sometimes pieces of a thrombus break off, travel through the bloodstream, and block vessels elsewhere. This is called an embolism. In other cases, the thrombus undergoes a process called organization, where new capillaries and connective tissue grow into it. Over time, it becomes fibrous and thickens the vessel wall, as in atherosclerosis. The body also has a fibrinolytic system that helps dissolve clots, keeping them from spreading too much. Emboli are not always pieces of thrombus. They can also be fragments of tissue, such as fat from bone marrow after a fracture, or amniotic fluid during childbirth. Tumor cells, bacteria, and even parasites can act as emboli. Air bubbles and nitrogen gas can also block vessels. Arterial emboli usually come from clots in the left atrium or ventricle of the heart, often due to myocardial infarction or valve disease. They can block blood flow to the brain, kidneys, or spleen, causing infarction in those organs. Venous emboli usually come from deep veins in the legs or pelvis. These travel to the right side of the heart and into the lungs, causing pulmonary embolism, which can be life-threatening. When blood flow is cut off, we call it ischemia. Ischemia means that tissues are starved of oxygen and nutrients because blood cannot reach them. It can happen because of thrombosis, embolism, atherosclerosis, external pressure, or spasm of the artery. If ischemia is mild or develops slowly, the tissue may adapt through atrophy or fibrosis. But if it is sudden and complete, the tissue dies, and this is called infarction. Infarction can be pale or red, depending on the situation. Pale or anemic, infarction appears white and is common in solid organs supplied by end arteries, like the heart, kidney, spleen, or brain. Red or hemorrhagic, infarction appears dark and bloody. It tends to occur in tissues where blood can enter from more than one source, such as the lungs or intestines, or in cases where a vein is blocked. After infarction, dead tissue is treated like a foreign body. Immune cells move in, break it down, and eventually new connective tissue fills the space. Over time, this forms a scar. Finally, edema is another important circulatory disorder. Edema means excess fluid accumulating in the tissues. It can result from several mechanisms. Increased venous pressure, as in right-sided heart failure. Decreased plasma oncotic pressure, as in kidney disease with protein loss. Lymphatic obstruction, as in filariasis or after surgery. Or increased capillary permeability, as in inflammation. Edema can be localized, like swelling in the legs due to a blocked vein, or ascites from liver cirrhosis. It can also be generalized, such as in heart or kidney failure. In summary, the body has intricate mechanisms to balance clotting and circulation. When those mechanisms are disturbed, through thrombosis, embolism, ischemia, infarction, or edema, the result can be life-threatening changes. These processes are central to understanding many diseases, especially those of the heart, brain, lungs, liver, and kidneys. Shock is a life-threatening condition in which the circulation fails to deliver sufficient blood to the tissues, resulting in inadequate oxygenation and organ dysfunction. It can be classified into several types. The first is hypovolemic shock, which arises from the loss of circulating fluid volume. Severe hemorrhage, dehydration, or major fluid loss from burns can all precipitate it. The second is cardiogenic shock, in which the pumping ability of the heart suddenly fails. When cardiac output falls sharply, as in acute myocardial infarction, blood flow to the organs becomes critically insufficient. The third is obstructive shock, caused by a physical block in the circulation. Pulmonary embolism, cardiac tamponade, and tension pneumothorax are classic causes. The fourth category is distributive shock, in which blood is maldistributed rather than lost or blocked. This group includes anaphylactic shock from type 1 allergic reactions, septic shock from overwhelming bacterial infection, and neurogenic shock from sudden loss of sympathetic vascular tone. Hypertension, or high blood pressure, is another major disorder of circulation. It is defined according to systolic and diastolic pressure levels. Optimal blood pressure is below 120 over 80 millimeters of mercury. Normal values are below 130 over 85. When systolic pressure reaches 130 to 139 or diastolic 85 to 89, this is considered high normal. Stage 1 hypertension is 140 to 159 systolic or 90 to 99 diastolic. Stage 2 is 160 to 179 systolic or 100 to 109 diastolic. Stage 3 is 180 systolic or higher, or 110 diastolic or higher. Two major forms are recognized. The first is essential or primary hypertension, which accounts for over 90% of all cases. It often begins in middle age and progresses slowly over years or decades, earning the label benign hypertension. However, if left unchecked, it leads to left ventricular hypertrophy, atherosclerosis, and widespread arteriolar changes. The causes are multifactorial, involving genetic predisposition, salt intake, obesity, body type, occupation, and psychological stress. Occasionally, essential hypertension runs a malignant course, rising rapidly and sometimes causing death within a short span. The second form is secondary hypertension, in which an identifiable underlying disease drives the pressure upward. Renal hypertension is the most common. In this case, narrowing of the renal arteries, often due to atherosclerosis, reduces kidney perfusion. The juxtaglomerular apparatus then secretes renin, activating the renin-angiotensin system, which raises blood pressure. Hypertension produces dangerous complications. In the heart, the increased workload forces the myocardium to contract more powerfully, thickening the ventricular wall. Eventually, the strain can lead to congestive heart failure. In the vessels, hypertension accelerates atherosclerosis, predisposing to myocardial infarction, aneurysms, and arterial dissections. In the small arteries and arterioles, hyaline arteriosclerosis occurs. Plasma proteins seep into the wall, and extracellular material accumulates, producing a smooth, glassy thickening that narrows the lumen. Over time, these changes compromise blood supply to critical organs. When we talk about inflammation, we are describing one of the body's most fundamental protective responses. It is what happens when the body encounters harmful stimuli, things like bacteria, viruses, chemical substances, physical injury, radiation, or even ultraviolet light and heat. Clinically, inflammation has what we call the 4 cardinal signs: redness, heat, pain, and swelling. Sometimes physicians also add a 5th sign, which is loss of function of the affected area. Now, in the case of acute inflammation, the story begins with local circulatory changes. Imagine that tiny arterioles briefly constrict, causing temporary ischemia. Soon after, substances such as histamine cause those vessels to dilate. Blood flow increases, a process called congestion, and because the blood slows down in those widened channels, the junctions between the endothelial cells loosen. As a result, fluid rich in proteins leaks out of the vessels into the tissues. This leakage is called exudation, and the fluid that accumulates is known as exudate. But fluids are not the only thing to leave the bloodstream. White blood cells also begin to migrate. On the surface of endothelial cells, special adhesion molecules appear, selectins. On the surface of white blood cells, other adhesion molecules called integrins respond. This allows the white blood cells to stick to the vessel wall, squeeze through the gaps between cells, and move out into the surrounding tissue. Once outside, they do not wander randomly. They move in a directed way, guided by chemical signals, toward the site of injury. This guided movement is called chemotaxis. At the site of inflammation, different types of white blood cells take part. Neutrophils arrive first. They are highly mobile and use enzymes from their lysosomes to kill bacteria and digest damaged tissue. Eosinophils appear in large numbers during allergic reactions or parasitic infections. Basophils, though fewer in number, release histamine and similar chemicals that amplify vessel dilation and permeability. Then we have the lymphocytes. T lymphocytes orchestrate cell-mediated immunity, while B lymphocytes mature into plasma cells that produce antibodies. Those antibodies attach to antigens, helping to neutralize invaders. Monocytes circulate briefly in the blood, then enlarge and settle into tissues as macrophages, which are powerful phagocytes, They engulf bacteria, release cytokines, and direct tissue repair. Let's pause for a moment to highlight the role of cytokines. These are signaling proteins, tumor necrosis factor, interleukins, and chemokines that coordinate the immune response. Alongside them, growth factors such as PDF, FGF, and VEGF stimulate new blood vessel formation, cell proliferation, and fibrosis. Other mediators, prostaglandins, leukotrienes, nitric oxide, and reactive oxygen species help to widen vessels, attract leukocytes, or destroy microbes. Another essential system is the complement cascade, a group of plasma proteins made in the liver. Complement proteins can coat pathogens, making them easier to ingest, a process known as opsonization. They can assemble into a membrane attack complex that literally punctures microbial cell walls. They recruit more leukocytes, and they help clear immune complexes. At the very heart of inflammation lies phagocytosis, the process of engulfing and digesting harmful particles. Neutrophils and macrophages are the primary phagocytes, and they are drawn toward microbes by chemotactic signals. Once they arrive, they swallow the invader and digest it with powerful enzymes. Finally, we have the reticuloendothelial system, or RES. This is a widespread network of phagocytic cells located in the bone marrow, liver, spleen, lymph nodes, and connective tissue. They act like guardians scattered throughout the body, continuously monitoring for invaders, engulfing them, and coordinating immune defense. So, to summarize in a single flow, inflammation begins as a local vascular event, expands into cellular migration and chemical signaling, and engages the body's most powerful defense cells and systems to neutralize threats, clear debris, and set the stage for healing. When we classify acute inflammation, we encounter several distinct patterns that illustrate how the body reacts to injury. One form is called serous inflammation. This is characterized by a clear, watery exudate, and we often observe it in the runny nose of acute rhinitis, in ascites that accompanies peritonitis, or in the blister that follows a burn. An insect bite or an allergic reaction can also produce this type of inflammation, where increased vascular permeability causes redness and swelling of the skin. Another pattern is catarrhal inflammation. This is typically found on the mucous membranes of the respiratory or digestive tract. In such cases, the exudate contains mucus and serous fluid, and the condition is usually accompanied by mucosal swelling and the shedding of epithelial cells. A classic example is catarrhal rhinitis. If this process becomes chronic, it may lead to thickening of the mucosa and the formation of inflammatory polyps. A more severe form is fibrinous inflammation. Here, the exudate contains large amounts of fibrin, and it is seen in inflammations of the pleura, pericardium, or peritoneum, and in pneumonia. If the fibrin is not fully degraded or absorbed, the inflamed surfaces may adhere to each other, resulting in fibrous adhesions. Diphtheria in the pharynx is another striking example, where a pseudomembrane forms. The most classic and dramatic type of acute inflammation is purulent or suppurative inflammation. This is caused by pyogenic bacteria such as Staphylococcus, Streptococcus, or Pseudomonas, and is characterized by the formation of pus through the massive accumulation of neutrophils. Within this category, several variations exist. Cellulitis or phlegmon involves a diffuse infiltration of neutrophils into connective tissue, producing redness and pain, but without a localized abscess cavity. Abscesses themselves represent localized areas where pus collects in a necrotic cavity, and if such an abscess ruptures outward, it produces an ulcer. In some cases, the pus finds a channel to the surface or another cavity, forming what is known as a fistula. When pus accumulates within a natural cavity of the body, such as the pleural space or the gallbladder, the condition is called empyema. Another destructive form is necrotizing inflammation. This occurs most often in mucosal tissues and involves widespread tissue necrosis. A gastric ulcer is a representative case where the mucosa is eroded by gastric acid, leading to ischemia and necrosis of the tissue. Not all inflammation remains acute. Sometimes it becomes chronic, either as a continuation of an unresolved acute process, such as an acute duodenal ulcer progressing into a chronic duodenal ulcer, or as a primary chronic condition from the outset, especially when the offending agent cannot be eliminated. Examples include chronic hepatitis B or C, glomerulonephritis, rheumatoid arthritis, and autoimmune disorders. In chronic inflammation, the dominant infiltrating cells are not neutrophils, but lymphocytes and monocytes. The process involves repeated cycles of tissue destruction and repair, and over time, fibrosis replaces normal tissue. In the liver, this process can be seen vividly in viral hepatitis, where lymphocytes infiltrate, hepatocytes are destroyed, and although some hepatocytes regenerate, inflammatory cytokines and growth factors stimulate fibrosis. Eventually, this results in cirrhosis, with nodular scarring and impaired function. There is also a specialized form of chronic inflammation called granulomatous inflammation. It is defined by the formation of granulomas, which are organized collections of macrophages and lymphocytes. In tuberculosis, the granuloma, often called a tubercle, shows epithelioid macrophages and multinucleated giant cells clustered together, with caseous necrosis at the center. Sarcoidosis is another disease that produces granulomatous lesions affecting the lungs, lymph nodes, and liver, among other organs. Finally, we must not overlook the systemic effects of inflammation. Local inflammation can send chemical signals throughout the body, producing fever and redness, or what we call erythema. Cytokines produced during infection or immune reactions often drive these systemic symptoms, and we see clinical changes such as increased acute phase proteins like C-reactive protein, along with elevated white blood cell counts. The heart responds with an increased pulse rate, and blood pressure may rise. In severe infections, particularly in sepsis or bacteremia, the massive release of cytokines can disrupt the function of major organs. Disseminated intravascular coagulation may develop, blood pressure collapses, and the patient may fall into septic shock, a life-threatening condition. In this way, acute and chronic inflammation represent not only local defensive reactions, but also systemic processes that can affect the entire body. They reveal how intimately damage, defense, and repair are linked, and how, if unchecked, the very mechanisms meant to protect life can themselves lead to lasting harm. When we speak of immunity, we are referring to the body's ability to defend itself against infections that occur repeatedly throughout life. The immune system works in layers. When pathogens first invade, the body immediately responds with innate immunity, which is driven by phagocytic cells such as macrophages and neutrophils. This natural immunity acts as the first barrier. Over time, the more specialized adaptive immunity becomes active. Lymphocytes recognize the specific invader, and through targeted immune responses, they eliminate it more powerfully and efficiently. In adaptive immunity, B lymphocytes produce antibodies that bind specifically to antigens, while T lymphocytes mount cell-mediated responses. Together, they create what we call the immune response. T lymphocytes may directly attack cells carrying the antigen, while B lymphocytes release antibodies that neutralize or mark invaders for destruction. The immune system also recognizes what belongs to the self. This state is known as immunologic tolerance. When tolerance is maintained, the immune system will not attack its own cells or tissues. But if this tolerance breaks down, the immune system may mistakenly attack the body, resulting in autoimmune diseases. Structurally, the immune system is remarkable because lymphocytes, its central cells, circulate freely through blood and lymphatic vessels and can trigger immune reactions in many parts of the body. Lymphocytes originate and mature in central lymphoid tissues, such as the bone marrow and the thymus, while peripheral lymphoid organs, including the spleen, lymph nodes, tonsils, and lymphoid tissue in the skin and mucosa, serve as gathering sites for immune activity. Although lymphocytes and monocytes are the principal immune cells, many other blood cells from the bone marrow also contribute directly or indirectly. Among lymphocytes, there are four main groups. B cells are responsible for producing antibodies. T cells develop from stem cells in the bone marrow that migrate to the thymus, where they mature and acquire T cell receptors and differentiation antigens. Helper T cells, often called CD4+ cells, secrete cytokines to stimulate and guide other immune cells. Cytotoxic T cells, marked as CD8+, directly attack target cells that display antigens. Natural killer cells, which are considered a form of immature T lymphocyte, do not require prior sensitization to antigens. They can destroy certain tumor cells and virus-infected cells, making them important in early defense and tumor surveillance. Phagocytic cells are also crucial. Macrophages, which originate in the bone marrow and circulate as monocytes, become specialized in different tissues. They are known as Langerhans cells in the skin, Kupffer cells in the liver, and microglial cells in the brain. Neutrophils and eosinophils also play key roles. Neutrophils are especially effective against proliferating bacteria and smaller organisms, while eosinophils are important in fighting larger parasites. Basophils and tissue mast cells, filled with granules of histamine and serotonin, release their contents when antibodies on their surface bind antigens. This process, called degranulation, spreads inflammation and underlies type 1 allergic reactions. Antibodies themselves are highly specialized glycoproteins produced by plasma cells, which are differentiated B cells. They react specifically with antigens, neutralizing them or marking them for phagocytosis. Different classes of antibodies serve different roles. Immunoglobulin G, or IgG, is the most abundant in serum and plays the leading role in defending against infection. It is also the only antibody that crosses the placenta, giving newborns temporary immunity from the mother. Immunoglobulin M, or IgM, is the first antibody to appear during an immune response, and although it is large in size, it is crucial in neutralizing and agglutinating bacteria and viruses. Immunoglobulin A, or IgA, is found in secretions such as saliva, tears, and intestinal fluids, and it is present in large amounts in colostrum, giving infants protection at the mucosal surfaces. Immunoglobulin E, or IgE, is the antibody responsible for allergic responses. Another essential part of immune defense is the complement system, a series of plasma proteins produced in the liver. Complement proteins enhance the effects of antibodies, helping to kill microbes and lysis cells. Once activated, they attract phagocytes to sites of inflammation, enhance phagocytosis through a process called opsonization, and ultimately form membrane attack complexes that puncture the surface of pathogens. In diseases such as systemic lupus, erythematosus, or glomerulonephritis, complement levels in the serum may decrease because complement is excessively consumed in antigen-antibody reactions. Finally, when an antigen enters the body, the immune response begins. B cells may be stimulated to produce antibodies, or T lymphocytes may proliferate to mount cytotoxic activity. Antigen-presenting cells, often macrophages, process the antigen and display its peptide fragments bound to MHC molecules on their surface. These are then recognized by T cells, which are activated to direct the immune response through cytokine release, antibody production, or direct cell killing. Thus, immunity represents a dynamic, multi-layered defense system that moves from innate protection to adaptive precision, involving a vast network of cells, molecules, and organs, always balancing between defense against external invaders and tolerance of the self. Allergic reactions are classified into several types according to their underlying mechanism. The first is known as Type 1 hypersensitivity, also called immediate or anaphylactic type. This is the mechanism behind conditions such as bronchial asthma, allergic rhinitis, and urticaria. In these cases, IgE antibodies, sometimes referred to as reagenic antibodies, are bound to the surface of mast cells and basophils. When a specific allergen binds to these antibodies, the cells release chemical mediators such as histamine, serotonin, and leukotrienes. These mediators trigger vasodilation, increased vascular permeability, smooth muscle contraction, and tissue damage. The second type is called Type 2 hypersensitivity, or cytotoxic type. In this mechanism, antibodies such as IgG or ImG bind directly to antigens present on the surface of cells, including red blood cells, often with complement involvement. This leads to cell lysis or destruction. Autoimmune hemolytic anemia, thrombocytopenic purpura, rheumatoid arthritis, and Hashimoto's thyroiditis are examples where this type of reaction is at play. Type 3. Hypersensitivity is also known as the immune complex type. Here, antigen-antibody complexes, often involving IgG, circulate and deposit in tissues. These deposits trigger inflammation and tissue injury through complement activation. Lupus nephritis in systemic lupus erythematosus and glomerulonephritis are classic examples of this mechanism. Type 4, hypersensitivity, in contrast to the first three, does not depend on antibodies. Instead, it is mediated by cell immunity. This is why it is also called delayed type hypersensitivity. In this process, cytokine-activated macrophages and cytotoxic T cells cause direct tissue injury. A well-known clinical example is the tuberculin skin test, where swelling appears at the site of injection. Organ transplant rejection also follows this mechanism. Finally, there is a fifth type, sometimes described as the stimulatory type. In this case, antibodies bind to receptors, not to destroy the cell, but to overstimulate or block receptor function. This mechanism is implicated in conditions such as myasthenia gravis and Graves' disease. The immune system normally avoids attacking its own tissues, a state referred to as immunologic tolerance. But if tolerance breaks down, the immune system mistakenly targets self-antigens, and autoimmune diseases occur. Specific autoreactive T cells play a central role in damaging the body's own tissues. Among the representative autoimmune diseases is systemic lupus erythematosus, or SLE. This collagen vascular disease is more common in young women and is characterized by the presence of multiple autoantibodies, including anti-DNA antibodies. Another common autoimmune disease is rheumatoid arthritis, which often begins in young adulthood. It is the most frequent collagen disease, manifesting as chronic polyarthritis that primarily involves the joints, but it can also affect the skin, lungs, and nervous system. Systemic scleroderma, or scleroderma, is another example. In this disease, excessive collagen deposition hardens the skin, and fibrosis can also affect internal organs such as the lungs, heart, and digestive tract, leading to significant functional impairment. Raynaud's phenomenon is often associated with these circulatory disturbances. When the immune system fails to function adequately, whether due to congenital or acquired causes, we speak of immunodeficiency. In such cases, individuals become susceptible to opportunistic infections. Primary immunodeficiency results from genetic defects and often manifests in infancy or early childhood as recurrent infections. This may involve deficiencies in complement proteins, impaired phagocyte function, abnormalities in B cells, or combined defects in both T and B cells, producing severe combined immunodeficiency. Secondary or acquired immunodeficiency includes the well-known acquired immunodeficiency syndrome, AIDS, caused by infection with the human immunodeficiency virus. HIV preferentially infects CD4 plus T cells and macrophages, progressively destroying immune capacity and leaving the host vulnerable to a wide range of opportunistic infections. In addition, immunodeficiency can also develop in the context of chronic diseases such as diabetes, kidney failure, or collagen vascular disorders, as well as during long-term drug therapy. In severe cases, the outcome may resemble AIDS itself, with fatal opportunistic infections such as pneumocystis, pneumonia, or cytomegalovirus pneumonia. Thus, hypersensitivity, autoimmunity, and immunodeficiency represent three different phases of immune dysfunction. In one, the system overreacts against harmless substances. In another, it mistakenly turns against self. And in the last, it fails to protect the host. Together, they illustrate both the power and the vulnerability of the human immune system.